This afternoon we wanted to discuss the skeleton handouts, which is a document that James originally put together, I don't know, several years ago, to help the course attendee who's taking the myokinematic restoration course understand the positioning in the left AIC pattern and what kind of the goal is with the right AIC pattern. These handouts are in the myokinematic restoration home study and live courses. And recently, in the past year, we actually took the handout that James created and we created two separate handouts because the original handout is great. However, it has some non-compensatory activity and some compensatory activity going on in the same handout, which caused some confusion with some of the course attendees that brought to our attention. So this past year, Ron sat down and took a look at it, and we created two separate documents, which are now included with the home study and the live myokinematic restoration course. So this afternoon, we just kind of briefly wanted to go through what this document covers and how it might help you in understanding the left AIC pattern and then the goal of obtaining a right AIC pattern.
Excellent. Jen, thanks. There's a lot of activity in the Institute that is regulated by compensation and non-compensatory type movement. And it's activity that we have to look at to make decisions on what kind of a patient do we really have in front of us, how much of what they demonstrates related to this non-compensatory pattern they're in. In other words, they're following the normal rules of squatting, standing, and bipedal type activities with gait. And they really don't look like they're doing anything incorrectly, because if you really break it down, everything they're doing could be possibly correct. Obviously, they don't compensate a lot. But over time, if you get patterned, as we all know, we become very, very behaviorally minded subconsciously about the pattern we're in, and then we start to consciously recognize that we can manage this pattern by compensating, and maybe even reserving some of our function, reserving it, protecting it, getting more out of our day-to-day life by actually working in a compensatory manner. And things break down, joints break down, capsules break down. We rely on proprioceptive feedback that's now inconsistent with normal function and normal functional patterns. And that's why I really have always liked this document, Jen, because he did a great job in putting together a document that says here's a common position of the person who's standing on their right leg, and it's common positions of the left AIC pattern. A person who's got their center mass over to the right side, he went over the right and left hip, the right and left knee, and the right and left ankle. And then the goal of what we're trying to do with the Institute's methodology is to intervene by getting us to become as comfortable and knowledgeable about our left stance positions as we are our right stance positions. So our goal would be to establish a better right AIC pattern, if you will, than a left, which means our anterior chain on the right side, we want to use it as well as we are the left AIC chain for bilateral activity. And so the title for this document was called Associated Osteokinematic and Arthrokinematic Positions of the Left AIC Pattern. Human pattern, stance with center mass is shifted over to the right side, and then James did a good job outlining the goal. And then there were some issues in this document that really didn't give the reader the full picture in terms of what's going on with these three areas, the hip, the knee, and the ankle, when you compensate a lot. In other words, what do you do across both sides when you compensate a lot? So we broke it up into two new documents. And I understand it's in the Myokin manual, and I heard you tell Matt it's in one other place.
It's in the home study, and the live course. It's as a handout in the back of the course manual.
And now it's titled, the document to my left is titled Associated Lower Extremity Osteokinematic and Arthrokinematic Non-Compensatory Positions of the Left and Right AIC Pattern. So basically we're just looking at what's going on at the hip, and the ankle, with respect to how we stand on one leg versus the other leg. And I'm going to go over that with you just because I think it'll be helpful if we do that. And then compare those non-compensatory positions, and when you're in that pattern, to a document to my right that says associated lower extremity osteokinematic and arthrokinematic compensatory positions of the left and the right AIC pattern. And Jen, as I look at it, and I think the viewer has this in front of them, if you go to the common non-compensatory positions of the left AIC pattern lower extremity on the right hip, you'll see that our hip, our femur, is in a state of external rotation, okay, and our leg is in an adducted state, an extended state, and on the left side we have a femur that is more inwardly oriented, again because the position our acetabulum placed it in, as was the right hip positioned by the acetabulum. That left hip is now inwardly orienting the left femur, and because that orientation is going on through ground reaction forces, our frontal plane activity on that side goes into abduction at the FA joint or at the femoral acetabular joint or at the AF joint on that left side. And then we consider that to be a state of hip flexion. You're more in your hip is anteriorly oriented, or anteriorly position would be a better word, rotated. And the things that go along with that, as outlined in the document you're looking at, would be IR, abduction, and flexion on the left side. If we stop there and just go right over to the other side of that page, and we'll see just the opposite of that listed, because that is really kind of our goal. Our goal is to get patients and our individuals we're working with that have a problem with movement to the left, Jen, is to actually just flip those three planes of activity. So on the right side you'd see hopefully more internal rotation, and along with that this abduction and flexion that's necessary to get your body weight shifted over to a hip on the left side that should now hopefully understand what external rotation, sensory input's all about, adduction and extension through that hip. And Jen, you can...
I think one of the things, just to chime in right here, is when people see on this non-compensatory pattern activity page, is that we say the goal on the left hip is to get ER, and some people may be like, wait a minute, we want to get IR on that left hip. But one of the things to make sure is that we don't want ER in an AF-ER position on the left side. We want to make sure that the left hip can ER from a left AF-IR position. So usually you will see with your algorithms in that myokinematic restoration course that you're pretty much doing all IR activity on that left side. You're doing AF-IR and you're doing FA-IR, but eventually that patient has to learn how to be in an AF-IR position and get FA-ER.
And there lies the problem, because if the patient's ability now to actually, for lots of reasons, if their ability becomes challenged high enough, their ability therefore to shift their center of mass over the left side, again for lots of reasons, it could be vestibular, it could be through the ankle itself, it could be the spine's coupling, lots of areas, and lots of neurological and lots of orthopedic reasons for things that now will not allow them to shift to the left side. When you get into a position where you need that internal rotation established on the left side through the ground, especially when you're in a ground or closed kinetic chain position, and you don't have the ability to get into what we call an AF-IR state, well, the first thing that happens is the femur will externally rotate, and we call that compensation. So it's not good if you're now compensating with things in your body that doesn't really change the entire dynamics of your tree, but changes a part of it. And we feel that, Jan, this is a major part of what's going on with individuals that walk into your clinic with shoulder problems, neck problems, whatever they may be having going on at the same time. A lot of these problems are generated by compensatory activities that are really taking place at a very high level through the pelvis, the low back, the femur area, because that's kind of where they shift, where we feel ourselves shifting. The momentum is actually being experienced, the forward progression is being experienced. So, for example, of someone who cannot get into AFIR and then generates that AFIR in a phony way or substitutional way through the hip is what that second page is all about. But I like the way this is now put together. If you look at the ankle on the right side, the ankle on the right side will be complementing your right hip external rotation. It'll therefore be in the calcaneus will be more in an inverted state. It's kind of a supinated ankle, if you will, if you can kind of consider it that way. We didn't write that, but
lateral border of your right foot, they'll tend to wear out that lateral border of their right foot more easily.
Because of that inversion and because of the transference of the mass over to the lateral border. And on the left side, you'll have just the reverse. You'll have more of an everted type of a foot. And we go over this in the I&I course, the instability and impingement course, where we talk about how to regulate ankles a little better through PRI activities to reduce the compensatory need if you're challenged by becoming unable to get out of that pattern. The right ankle on a person who is now shifted over the left should be just the reverse of that. It should be in an everted state, and the calcaneus on the left should be in a more of an inverted state. So this varum and valgum at the ankle, and this or eversion and if you will, if you evert an ankle, that is varum, and this varum and valgum, which corresponds to eversion and inversion of the ankle, can generate frontal plane activities all the way up that could become very compensatory, and it doesn't always happen just on one side, it can happen on both. So I like the way this now looks. The arrows are very helpful. You can see where the arrows are now demonstrating pelvis orientation or pelvic rotation, femoral rotation, which side of the chest wall is compressed, which side is more open. I like it. On the other handout, I'm really excited about what we did with this one, Jen. We're now looking at compensatory issues and some of the more common ones. And the first one that you see is a common compensatory position of the left AIC pattern lower extremity. You see that a lot, where people have a tendency, Jen, to stay on that right leg. I'm going to let Jen go over this, and then I'm going to comment on what she's talking about as she reads to you what you have in front of you related to the compensatory position page.
Yeah, I think the biggest thing, or the most common compensatory that you're going to see in this left AIC pattern is going to be with that left hip, especially the external rotation component of that left hip, because if you aren't able to shift over into left AFIR or that right AIC pattern, and rather instead you turn that femur out to move that foot and that leg straight ahead, you're going to get compensation and pathology in that anterior hip capsule on the left side. So I think that's probably the biggest region that you're going to notice these compensatory patterns. But you could have a right hip that's stuck in IR, and really this is all just driven by your inability to get out of the left AIC pattern and get off that right leg correctly and getting over to that left leg. You may have patients that say, I'm getting over to my left leg, I can do it, I'm
Right.
here, look at me, but they're, like Ron said, they're doing it in a phony way, or they're compensating through a low back or other compensatory strategies to try to do it, because they aren't, they have no concept of what AFIR is on that left side.
And what Jen just said is really probably a very, I would suggest a real simplistic way to think about this, because if we get too complex with this, then we're losing probably a sense of what we're trying to establish with any program we're putting together. In other words, individuals that compensate through this hip, like she just discussed, are individuals who are trying to walk straight ahead, because they may be trying to walk straight ahead, but the orientation of their spine is really off to the right, because they love the right side and their right femur is externally oriented because of the position the extended hip is in, and the left femur is inwardly oriented because the position the left flexed hip is in. And so as they compensate to walk straight, they wouldn't want to create more ER on the right side. They'd want to stay in IR on the right side because that's what's going to allow them, at least for the right leg, to push them off by staying straight. On the left side, to get their foot out in front of them, they're going to have to externally rotate. So most of our compensatory issues with individuals that are human are going to be on the left side for the mere reason that we're trying to walk a straight line. If we had patterns and we were in situ where our organs were rearranged and we had a brainstem that was different, we had different parts of our anatomy established around dominance in a different pattern. We evolved and we over time appreciated the need to survive by shifting our body weight over to the left side more than the right. This would be a completely different discussion. But since we are humans that are more centered over our right side, what Jen said is very true. We see more pathology, more compensatory activity naturally occurring over time on that left side. And the differences, Jen, between the two pages also include what I call torque and twist or tension going through a new artificial hip area, and that would be the knee. When the knee starts to become sandwiched between the ground, that doesn't change. The ground isn't moving on you. You're moving on it. The ankles may be the very same as they were on the previous document. We didn't doctor those up. Now we see lots of patients that have compensatory issues at the ankle, but now we're getting into some complexity, yeah. And it's fair to do that. But these two documents are saying, wait a minute, just hold back a little bit. Remember, before we treat the ankle, we really have to understand possibly why the ankle is doing what it's doing. And maybe the ankle is the reasoning for what's going on with the hip. There's no question. I see that, and we see that all the time. And it's really going to be difficult to assess what came first at this point. But we do know this. If we don't strategically put a program together that's going to acknowledge the early on generated compensatory activity of our behavior through the left hip specifically, it's probably going to be difficult to manage any compensatory pattern, any movement strategy, any of the strategies Dr. Sarman's talked about, without really considering what's going on both with compensation and non-compensation. If you're a person that likes to look at angulation of lever arms bones, positions of bones, and orientation of triosseous function. So I think it's really safe to say that the more simple we stay here regarding what's going on with that hip, which these two documents do a really good job of, the better off we're going to be. So underneath of Jen's discussion, she has a right knee that's going to be more in a state of valgus, and a left knee that's going to be more in a state of varum, because the ankle is still in the same position that it was on the prior page. Jen, why don't you go ahead and talk about the other side?
So really, if you want to grab a highlighter or a pen, the only thing that changed between these two documents is the transverse plane activity occurring at the hip. So IR and ER is the only thing that has changed between the non-compensatory and the compensatory document that are sitting in front of you, or that you printed off, or that you got in your myokinematic restoration course manual. The ankle hasn't changed at all from the previous document, and the frontal plane and sagittal plane activity at the hip hasn't changed at all. And like Ron said, the knee is now going to suffer some compensatory activity because of that sandwich position. But that might kind of highlight the two differences between these two documents for you. And as Ron said, the ankle, of course, there's a lot more that can be going on at the ankle, and that is discussed in that impingement and instability course in quite detail. The calcaneal instability that can, be holding up a program for you if you are in the scenario where you've addressed the left AIC pattern from the hip or the pelvis already.
What's so cool about this, Jen, is that if you take a look at James' initial document, he put a document together that's really representative of what you most typically will see. Okay? And that's what I love about it. I mean, it really is well written. And under the goal, it says, we want, the goal is to get in the right AIC pattern. But under that goal, there is some definitions of what a right hip and a left hip should look like that really reflects what we think is compensatory. In other words, it's a compensatory activity. You're seeing it, you see a lot of it, but now it's a little confusing to the person taking the course or anybody looking at it that says, wait a minute now, if that's our goal and they're compensating, are they really compensating, or are they really in a position we want to keep them in? That's where it gets a little confusing. So all we're really doing is just really establishing a better way to look at the human body from a non-compensatory, clean, non-compensatory positional state, and then look at the most likely positions you're going to see with compensation. And James hit it. He hit the right side. That's where you're going to see the main changes of compensation.
The left side.
Left side, excuse me. He hit it. The left side's the place you're going to see the main changes for this associated compensatory patterning that you'll see in upright individuals especially. So I think we covered that, Jen. I think that's really what we intended to do here, and hopefully this helped. Now, for those who've not taken a MyoKing course and you don't have this in your manual, you're not going to have a problem with it, because you got two handouts that say not compensatory and compensatory. For those of you who've taken the courses in MyoKing, you got a great handout. We just cleaned it up a little bit as it relates to this discussion on compensation. I hope this helped this afternoon, and I hope it helps you understand better what our goals are. And Jen, did you want to end with any other comments?
No, I think that's great.
All right.
Thank you
very much.